if you want to use this, you can. Yeah, if you want to put that on now.
For Q&A.
Okay. Good morning. Want to welcome you all to this presentation on behalf of the Department of Epidemiology and Biostatistics and the Center for Health and Community. We're very pleased to have you all here. I'm very pleased to introduce Sir Michael Marmot to you. It's a pleasure to welcome Michael here to UCSF and San Francisco. Michael and I knew each other first back in the early 70s when we were students together at Berkeley in our master's degree. And he's gone on to a stellar career, and one in which he has risen in prominence as an intellectual leader in the field of epidemiology and health disparities, and one of our most famous epidemiologists. So we're very, very proud to have him and to have him representing us as a discipline. He's now the director of the Institute for Health Equity at the University College London, and he's led groups for about 35 years now in studies of social determinants and health disparities, most famously the Whitehall studies, where he's established the importance of the social gradient in British civil servants and other populations after that. His accomplishments are highly significant, and I put a p-value of 0.0001 on that, or maybe even more zeros. He has over 1,000 publications and over 70 awards and prizes, and was recently elected president of the World Medical Association. So this isn't something that he had planned, but his presidency previous to that of the British Medical Association led to his being elected by that group. So prominence in both the academic and professional areas. So beyond his academic accomplishments and titles, I had a conversation with Michael this last year about the impact of work that we do, and I meditated a bit on that for his own career, and he's had a huge impact. People have noticed the work that he has done. Epidemiologists have noticed the term social determinants of health is now something that slips from the tongue of any graduate student. Researchers in the biomedical, social, and behavioral sciences, have noticed and been forced to deal with the implications of the social gradient. Ministers of health, prime ministers, presidents of countries have noticed and asked him to chair committees and to address their own country's problems with social inequities. And multiple commissions, as you'll hear about this morning, on social determinants of health have noticed and asked him to chair their activities. And finally, the Queen of England has noticed, and so we have Sir Michael Marmot now to talk about. So Michael has recently published a book, recently, like in the last month. It's called The Health Gap, Challenge of an Unequal World. And he addresses in this book his experiences with health inequities on the world stage. And his lecture today will draw largely from his thinking and experiences that went into this book. So please welcome Michael Marmot.
Thank you. This is, in a way, coming home. As you heard from Bob, we were students together at Berkeley, Master of Public Health. But even before that, when I was a medical student in Sydney, I did an elective at UCSF. That's the good bit. Let me tell you the other bit. In surgery. But you just heard from Bob in the introduction about the World Medical Association. This is really odd. I spent my whole career, my whole adult life, saying that the key determinants of health are not what doctors do to patients. The key determinants of health lie outside the medical care system. I know we're in a medical school right now. So to find myself president of the World Medical Association is really odd. And I said to these doctors, the World Medical Association is the representatives of national medical, so the president of the American Medical Association represents the United States on the World Medical Association. And I said to these doctors, who are all sort of medical politicians, remember why you went into medicine. Remember the motivation. You wanted to help people. You wanted to cure the sick. And my guess is you were probably concerned if some people were more likely to get sick than others, which would sensitize all of us in the medical profession to concerns about social justice. And I said these twin concerns with doing something about the sick and social justice should lead us. And then I said, we cannot, as doctors, stand idly by while the conditions that make our patients sick, that reside in society, are in operation. And the first line of my book is why treat people and send them back to the conditions that made them sick. So I'm trying to open another front. I'm working on the hypothesis that we can get doctors interested in health. We'll see how we go. I've written in my book about Baltimore, and then Baltimore erupted earlier this year. The precipitant for Baltimore erupting was the killing of a black man in police custody. But that wasn't the cause. The cause was the inequity in social conditions that are in Baltimore. And people commented at the time that what binds us together as a cohesive society is being threatened by gross inequities. And I would say those binds snapped in Baltimore. Now I'm being a bit loose here. It wasn't Baltimore that erupted. It was Upton Druid Heights that erupted. The poor part of Baltimore, life expectancy in the poor part of Baltimore is 63, and in the rich part is 83. What a coincidence that the riots happened in the part with the lowest life expectancy. The same happened when we had riots in London, in Tottenham. I had been showing figures that life expectancy in Tottenham was 17 years shorter than the best off part. They didn't riot outside Harrods in Knightsbridge. They rioted where one of my sons lives, but that's because of that. The housing costs are low enough that that's where young people have to live. They rioted in Tottenham. Now, I don't think ill health causes riots, and I don't think riots cause ill health. But I think deprivation, relative deprivation, is related to both of them. So, LeSean in Upton Druid, where he lives, half are single-parent families. Median household income in 2010 was $17,000. 4 out of 10 were under-proficient in reading in the 3rd grade. More than 50% missed at least 20 days of high school. 90% did not go on to college. Each year, a third, aged 10 to 17, were arrested for, quote, juvenile disorder. A third each year. Means by the time they get to age 17, only a minority will reach that age without a criminal record. And you know what that means for the rest of their lives, for their life chances. Coming to the age when you'd quite like to be employed with a criminal record makes that much less likely. And 100 non-fatal shootings for every 10,000 residents. And there were, if I remember, it's fallen off the end, and nearly 40 homicides. In Roland Park, I was at a meeting at that little-known university in Baltimore, and some young doctors said to me, "You can't sit here at Johnson," oh, I said it, and not see Baltimore. Come on, we're going to take you and show you Baltimore. And you don't have to go very far, it's quite small. To get from Roland Park to Upton Druid is a few minutes in a car. And we started in this leafy part with manicured lawns. I said, there's a person of colour. He was working in the garden. It's all white. And the other one's all black. And I think white and black has absolutely nothing to do with it. I don't think it's anything to do with the colour of somebody's skin. It's true in the US that discrimination, segregation, social disadvantage tend to go along colour lines, but that's not the issue. The issue is median family income was $90,000, not $17,000. 93% two-parent families, not one-parent families. They're all doing well in the 3rd grade. Only 8% missed 20 days a year. 75% completed college. And the kids in Roland Park stay out of the clutches of both the criminals and the police. And sometimes it's hard to tell the difference. But they stay out of the clutches of both of them. And so non-fatal shootings, no non-fatal shootings, and 4 homicides per 10,000, not 40, 1/10 the rate. And as I said, a 20-year gap in life expectancy. Now, when we think about health inequalities, I use the word inequalities or inequities, not disparities. Commonly, the word disparities in the US is taken to apply to racial ethnic differences. I talk about inequalities in Britain. In fact, in my book, I talk a great deal about inequities, the unfair inequalities that we think we can do something about. When we think about inequalities, commonly we think of poor health for the poor. And the poor do have poor health, but that doesn't describe it fully. The fact is, there's a social gradient. White women, white men, black men. There was a lot of publicity in the last week about a new paper that showed that white men with low education are doing badly. This was a slightly older paper that showed the same thing in 2012. But you can see the higher the education, the longer the life expectancy. It's not just that those with low education are doing badly, it's a gradient. So among white men, 67, 72, 79, 81. It's a gradient. It looks like having more education, there's not such a big black-white difference in women. There's a huge black-white difference in men. And I don't pretend fully to understand why that's still the case, but I presume it's at least in part saying that education doesn't capture the level of social disadvantage between black and white. And this was the recent paper that got a lot of press last week. And it is quite remarkable. US whites, non-Hispanic whites, so this is mortality age 45 to 54. And all these other groups, France, Germany, US Hispanic, UK, Canada, Australia, Sweden, it's all coming down, and US whites, it's been going up. And if you look at the paper, it's a gradient. The greater the level of education, the better off they're doing. In fact, this rise is somewhat bigger for those with intermediate levels of education and huge for those with low level of education. If you've got high level of education, you didn't get the rise. Why has it gone up? It's not lack of health care. It's drug and alcohol related poisonings. It's suicide. And it's chronic liver disease related to alcohol. When we published the report of the WHO Commission on Social Determinants of Health, I pointed to the fact that Glasgow, like Baltimore, has these huge inequalities right within Glasgow. In fact, at that time, it was a 28-year gap between the most deprived part of Glasgow and the most affluent part, and I'll come to that in a moment. And what are the causes? Alcohol and drug-related poisonings, suicide, alcohol-related, and external causes of death, violent deaths of one form or another. The same, the US. What's going on? Angus Deaton, one of the authors of the paper, talks about it as an epidemic of despair. I talk about it as disempowerment. And we've got good evidence from Glasgow that it is lack of control, disempowerment, that is related to these causes of death. It's not lack of health care. It's the nature of society that's responsible. So I've pointed to the gradient. These are data from England. This is in my book. In fact, most of these figures are in the book. Each dot represents a small area of England, neighbourhood, classified by level of deprivation of the neighbourhood. So the right hand here, we've got the least deprived, the most affluent, and they're the most deprived. And the top graph is life expectancy. Those who live in neighbourhoods that are nearly the most affluent, but not quite, have shorter life expectancy than those who live in the most affluent. All the way from top to bottom. The bottom graph is disability-free life expectancy. I was at Harvard early this year, and a professor trying to be the devil's advocate said, why should we care what you're talking about? It's the poor. And most of us are not poor. Why care? And it's interesting, I know you don't have the kind of political discussions in this country, but we in Britain, unfortunately, have some politicians who think people are poor because of their own choices. Now, you wouldn't have any politicians like that, surely, not running for president or anything like that. Well, so people of a certain political persuasion think that the poor are the architects of their own misfortune. If they didn't make all these silly choices, then they wouldn't be poor, and their poor health comes about because they don't know how to look after themselves. And if you're of a different political persuasion. You might say, well, it is a stain on a civilized society that people should live in poverty and should have ill health as a consequence. And I feel about the poor a bit like I feel about the Siberian leopard. I'm prepared to give $10 to help preserve the Siberian leopard, and then I go about my business. Either way, you think inequalities in health are about them, the poor. They're not about me. They're not about us, the non-poor. Now look at the gradient. This is about you and me. I was interviewed by a journalist yesterday and I said, this is about you, the writer, and your readers. We calculated it in England and the figures would not be very different in the US. Given that there's a 17-year gap between top and bottom in disability-free life expectancy, that on average, people in the middle are going to have 8 fewer years of healthy life as a result of this social disadvantage, compared with those at the top. 8 fewer years of healthy life means earlier onset of declining grip strength, of loss of mobility walking, of declining cognitive function, and shorter lives. The gradient means we're all involved. We have to improve society. So whether you think the poor are objects of sympathy or whether they're feckless and immoral, we're all involved. It's not just about the poor. The poor are part of us. They're part of our society. So I think the gradient is really quite profound. And my second answer, and it relates to what I've just been saying about the Deaton and Case paper, is that the average is not doing very well. Count 100 15-year-old boys in any American school, and 13 will fail to reach their 60th birthday. Is that a lot? Well, it's double the Swedish figure. It's worse than Costa Rica and Chile and Cuba. It's better than Turkmenistan. You'll be pleased to know. In fact, it's worse than 49 other countries. The WHO has 194 member states and 49 of them have better survival chances of 15-year-olds to 60. The US ranks 50th. Not looking good. And they die of the causes that I enumerated when talking about the Deaton Case paper. It's not a medical care issue. Even when it is a medical care issue, what about maternal mortality? A couple of years ago, I was lecturing to the American Gynecological and Obstetrics Society, and I congratulated them that the maternal mortality in the US is better than in the Ukraine, but behind Turkey. The US ranks 64th in maternal mortality, lifetime risk of a maternal death. And I said to these distinguished doctors, if you tell me that you have the best obstetric care in the world, I'll believe you. I have no reason not to. And if I asked you to write down on a piece of paper who the women are who are dying, my guess is you'd all write the same thing. The socially excluded, the disadvantaged, the undereducated, the illegal immigrants, people of color and the like. So even where we know medical care can solve the problem, nobody should die of a maternal-related cause. In the best-off part of Europe, it's 1 in 47,000. In the US, it's 1 in 1,800. So nobody should die. It's completely safe. Social determinants are impacting on who gets the care. So there's an intersection. Now, I don't think it's largely health care, but as I said at the beginning, I'm trying to get the doctors signed up here. And we see these gradients everywhere. under 5 mortality by wealth quintile, Uganda, India, Turkmenistan, Bangladesh, Peru, we see gradients. If you were in India, you wouldn't say, let's focus only on the bottom. If you were in the middle quintile, you'd want under 5 mortality as low as the top quintile. If you were in the top quintile in India, you'd want under 5 mortality as low as the bottom quintile in Peru. If you're in the top quintile in Peru, you'd want under 5 mortality, about 15, you'd want it to be the same as Iceland at 2. The gradient means we've got to deal with the whole of society, not simply the worst off. And it's not only about income. The Preston curve, I've taken it from Gapminder, show income per person at purchasing power parities for countries. At low levels of income, a small increase in income is correlated with a large increase in life expectancy. But once income at purchasing power parities gets to about $10,000, Cuba, Costa Rica, Mexico, all the way out here to Luxembourg with their ill-gotten gains, there's simply no relation between national income and life expectancy. Getting richer as a country doesn't mean getting better health. And we think about GDP growth all the time. We watch, did the GDP grew 0.2% last quarter, and is that a good thing or a bad thing? And, it's complete garbage. Complete garbage. It says nothing about the quality of our society. It tells us nothing about our social relationships. It tells us, I'm quoting Bobby Kennedy now, it tells us nothing about the joy of our children. It tells us nothing about the wonders of our poetry. It tells us nothing about whether young people in Baltimore feel they don't have a chance in life. GDP tells us nothing about that. But health equity tells us a great deal. So close is the link between the features of society and health and the fair distribution of health equity, that it tells us a great deal. And I can tell you that something's not going very well with US society because you're not doing very well on health and the fair distribution of health. And I would say that's what the political debate should be about. And I'm not political. If you believe that, you believe anything. So what can we do about all this? A great deal, which is why I wrote the book, to try and summarize what I thought I'd learned from the WHO Commission on Social Determinants of Health, my English review, Fair Society, Healthy Lives, our European review, work we're doing with the Eastern Mediterranean region, and now with PAHO in the Americas. So, start at the beginning of life. I talked about Carlton in Glasgow, where life expectancy when we looked was 54. First, it's probably gone up a bit now, but it's a 20-year gap between Carlton and Lindsay. And Jimmy had a single mother. She had a succession of partners, each of whom abused Jimmy physically, if not sexually. They moved house every year or 18 months. By the time he got into school, he was labeled as having a behavior problem. Hardly surprising if you know about the Adverse Child Experience study. Jimmy had them all squared, if not tripled. And as soon as he was old enough, he was labeled as a delinquent. Never had a proper job. Any money he gets goes into drink and drugs. his diet, if you could call it that, is pub food, fast food and alcohol. Had a series of short-term girlfriends, but there was some question of alcohol-fueled violent behaviour. And life expectancy in that part of Glasgow was 8 years shorter than the Indian average. Rich compared with India, but poor, deprived relative to all the things that you want in a civilized society. This is looking more generally. It comes from the 1970 British birth cohort study, and it's looking at cognitive development. Let's look at children, and it's following children from 22 months of age to 10 years of age. Let's look at children who at 22 months were in the 10th centile of cognitive development. If they grew up in families of low socioeconomic status, they remain low. There's regression to the mean, but Bob will explain what that is afterwards. He'll ask somebody else to explain it. So if they grew up in families of low socioeconomic status, they remain low on cognitive development. If they grow up in families of high socioeconomic status, they catch up. Now look at the children who at 22 months were in the 90th centile of cognitive development. If they grew up in families of high socioeconomic status, they remain high. If they grow up in families of low socioeconomic status, they decline. Let me be really crude about this. If you're poor and dumb, you stay dumb. If you're rich and dumb, just hang in. You'll catch up. It'll be all right. If you're poor and smart, sorry, that's not good enough. You've got to be rich too. If you're rich and smart, then you've got everything going for you. Now assume for the moment that all the differences at 22 months are biologically determined. There must be within a few meters of this building any hundreds, thousands of researchers all looking at the genetic determinants of everything. And let's assume for the moment it's all genes or whatever else. The differences at 22 months. And that the differences associated with the socioeconomic status of the family is social. The social trumps the biological. Now, not all the differences at 22 months are biological. The quality of early rearing really matters. We've got good evidence for that. But it shows quite how crucial the socioeconomic level of the family is. Now, why am I talking about this? We're talking about health inequalities. What's cognitive development got to do with it? Well, you know how it works. Readiness for school, cognitive development, social and emotional, behavioral development, all go into readiness for school, has a powerful predictive effect on how children do in school. That determines whether they're going to be one of the dropouts or go on to college, which in turn determines whether you get a job, what kind of job, what your income is, where you live, all those key things that are correlated with better health. And it all starts at the beginning. And we've been monitoring this in England since I did my English review. This is the proportion of children age 5 who have a good level of development for each local authority by an index of multiple deprivation. So these are the most affluent and they're the most deprived, and you see the relationship. I showed this graph in Her Majesty's Parliament, and one sportsman said the multiple R squared of that correlation would be quite low. And I thought that's what members of Parliament most want to discuss, proportion of variance explained. So I said what that gentleman is trying to say is that there's variation around the line. And that suggests two strategies. One strategy to reduce early child development is reduce deprivation. And another strategy is to ask why, for a given level of deprivation, some local areas are doing better than others. And it's almost a Rorschach test of political orientation. People on the right say it's poor parenting. And people on the left say it's poverty. And I say they're both right. Degree of poverty and deprivation impacts on parents' ability to be good parents. I've just been reading a new book called $2 a Day. I don't know if anybody knows it, about the US. There are 1.5 million households in the US living on $2 a day in the US. Now read what these families are going through and ask, are they reading to their children on a daily basis? A book? A book? A house? A bed? Reading to children when you put them to bed presumes you've got a bed and you've got a house and you've got a book, assuming you're literate in the first place. So the quality of the social environment impacts on parents' possibilities to be good parents. If you've got a bed and a bedroom and a book, then you've got the possibility of reading to your children. And the evidence shows that good services can make up the difference. Just coming back, the median, when we were doing this, the median was 59%. Only 59% of children in England were classified as being ready for school at age 5. And I thought, how's that possible in a brainy country like England? Only 59%. Well, when we look at UNICEF figures on country comparisons on child well-being for material, health, education and behaviors in the early 2000s and the late 2000s, there's the United States, ranked 20th, equal 20th, now all by itself on the bottom. The UK was equal with the US. We've soared up to 16th. I do like lecturing in the US. It's the only big country that makes me feel even slightly decent about my own. This is dreadful. And when journalists were asking, why did this happen, that there could be a rise in middle-age mortality, that's where it starts. It starts at early life. And then I get asked, is there any evidence we can make a difference? Oh, look round the world, for heaven's sake. Look at what's happening to people of higher privilege and status. There's huge amount of evidence that we can make a difference. If we look at cognitive test scores at age 7 for reading and maths, low birth weight, not being breastfed, maternal depression, lone parent, median family income less than 60%, parental unemployment, maternal qualifications, damp housing, social housing, area deprivation. These are British data. And you can see how each one of those another notch off the reading scores and the math scores. We know a great deal. And we can do things. These are European data. Child poverty is defined as less than 60% median income. And it's showing child poverty before and after taxes and transfers. So compare Latvia and Sweden. Before taxes and transfers, child poverty in Latvia was 35%, in Sweden was 32%. After taxes and transfers, child poverty in Latvia was 25%. In Sweden, it was 12%. The Minister of Finance has his, it's usually a him, hands on the lever that can make a huge difference to health inequalities, probably a bigger difference than the Minister of Health. 2 years ago, I did the opening address to the American Public Health Association meeting in Boston, and there were 7,000 people in this football stadium, whatever it was, and I showed this figure, and then I showed the comparable US figure. The US is worse than Latvia. And I looked at these 7,000 people and said, you live in a democracy. This must be the level of child poverty that you want. Otherwise, you'd elect a government that did something different. And I said, is there a politician in the land who says we don't care about the children? And a voice called out, you'd be surprised. So there is a great deal. Oh no, there's nothing we can do. We haven't got a randomized controlled trial that reducing poverty improves early child development, or that the fiscal policy would reduce child poverty. So there's nothing we can do. Sorry, I meant to say that. And we see it more broadly. These figures from Latin America look at the percent of children who were enrolled in preschool, age 3 to 5. So Cuba, Costa Rica, Cuba's 100% of children enrolled in preschool, Costa Rica and Chile up around 90%. Paraguay, Dominican Republic, Colombia, very low levels. And then on the same graph, it's got the reading scores in the 6th grade, the percent of children who got high reading scores in the 6th grade. The greater the proportion enrolled in preschool, the better the reading scores in the 6th grade. I know correlation is not causation. One could have nothing to do with the other. And it just turns out that the best life expectancy among these countries is Cuba, Costa Rica and Chile, and the worst is Paraguay, Dominican Republic and Colombia. I think it starts at the beginning of life, it goes on to better education and translates into better health. We said in the report of the Commission on Social Determinants of Health that it's not just the conditions of daily life, but inequities in power, money and resources that give rise to these conditions of daily life. When you finished explaining regression to the mean, you can explain what intergenerational earnings elasticity is. I can tell you what it is. This is looking at the correlation of income of parents with the income of their adult children. If the income for countries, and I'll come back to the Gini coefficient in a moment, if the income of adult children exactly resembles the income of their parents, a country would score 1. There would be no social mobility. High-income parents have high-income children, low-income parents have low-income children, and middle-income parents have middle-income children. Country would score 1. If there's no relation between parental income and childhood income, country would score 0. So Denmark, Norway, Finland have very little correlation between parental income and income of adult children, a high degree of social mobility. The US and the UK have much less social mobility. Who your parents are has a big impact on what happens to you. And it's correlated with the Gini coefficient. The Gini coefficient is a measure of income inequality. The greater the income inequality, the less social mobility. In other words, the greater the distance between the rungs of the ladder, the greater the difficulty of getting from one rung to the next for the next generation. And this is across the whole social gradient. So the level of income inequality is impacting on the life chances of the next generation. There isn't a politician anywhere who would claim they're against equality of opportunity. That's easy. No politician's going to stand up and say, I think people born in Delaware should have smaller life chances than people born in Utah. It's garbage. So the problem is that the steeper the inequality, the more the playing field is tilted, the less equality of opportunity that we have. I'm going to run out of time. Education is, of course, vital. You know this. No education, secondary or higher, infant mortality. In every country, mothers with secondary or higher education have lower infant mortality than those with no education. And if you look between countries, the variation between countries is somewhat less for mothers with more education. It's bigger for those with no education. If you're born in a country that has generally high infant mortality, then having more education is a partial counter to that. So education of women is good for the health of their offspring. I showed you in an earlier slide, it's good for their own health. It relates to fertility. Primary, secondary or higher, and no education. Look at Bangladesh and India. Women with secondary or higher education, 2.5, 2.1 children per woman, births per woman. Education makes a big difference to women's period fertility rates. So their own health, the next generation, fertility, and if you're a sensitive disposition, look away now. This is the proportion of women agreeing that it is acceptable for a husband to beat his wife if she refused to have sex with him. In Mali, it was, in 2001, nearly 74% of women agreed with this proposition. It's gone down, but now look at education. The more the education, the less likelihood that women will agree with that proposition. Now, when you get involved in global health, the first thing you learn is to be culturally sensitive. They do things differently in other cultures. We should be sensitive to that. Surely, human rights trumps cultural sensitivity. The right of a person not to be beaten up because she wants to control her own body, her own sexuality, her own reproduction, has to trump cultural sensitivity. We know education is important. This is within-country maths results for the PISA, Program of International Student Assessment. The Chinese are doing brilliant. I was in Taiwan at the beginning of the week. Taiwan's right up there now, even better than Finland. But it's not just that they're doing well on average, it's the social gradient. This is by the economic and social classification. And there's the US, not doing brilliantly overall, and a very steep social gradient, as the UK does. So, not doing well on early child development, not doing terribly well on education. It's not such a surprise they're not doing very well on health. Fair employment and good work for all. There's a great deal we can say about the work environment. One thing we'd like work to do is to relieve poverty. And I said half an hour ago, that people have different attitudes to poverty. Certainly in Britain, politicians have started to talk, or been talking for some years now, about shirkers and strivers. The shirkers are the work shy. They're poor because they don't want to get ahead. And all politicians in Britain now are signed up to the importance of hard-working families who want to get ahead. They're the strivers. And somehow that, in politicians' fevered brains, is linked to poverty. The shirkers are in poverty because they're shirkers, and the strivers are not in poverty. Therefore, we should cut the welfare bills. This is people below the minimum income threshold, another word for poverty, by whether they're in workless households or working households. More than half, I think that's a majority, of people in poverty below the minimum income threshold are in households where at least one adult is working. And in those households where at least one adult is working, 3/4 of the adults were working. These families are below the minimum income threshold, not because they're feckless, not because they're lazy, not because they're shirking, because they're low paid. I happened to look the other day. Walmart's turnover for the year to January 2015 was $480 billion. I think the size of the UK economy is $2 trillion, so Walmart's tiny. I mean, it's not even 1/4 of the UK economy. And people who work in Walmart are on food stamps because they can't afford to eat. So the federal government has to subsidize Walmart. It only gave, of the 480, it only gave $7.5 billion to its shareholders. God only knows where they squirreled away the rest of it. Half probably went to accountants and the other half to lawyers, so they didn't have to pay tax. But this low pay, and the same in Britain, is being subsidized by the government. People are poor because they're not paid enough. That's why they're poor. It's nothing to do with their moral certainty or anything else. You could use this slide in a class of graduate students and spend the whole term thinking of causal explanations, different causal explanations for this. It comes from the UNDP Human Development Report, and it's the log of public, these are countries, log of public expenditure on health. Actually, they don't mean health, they mean health care. On health care and education per capita in 2000. And the Human Development Index in 2012. The Human Development Index is a combination of literacy, income, national income, and life expectancy. So I say you can think of all sorts of reasons why there'd be such a tight correlation. One of them is, if yours is the kind of country that spends a lot on healthcare and education, yours is likely to be the kind of country that has good literacy, good health, as well as good income. And I talked about income inequality. It's increasing in most OECD countries. This is just a rant. So you can ignore this. It's just a rant. But the rant is, we are systematically misinformed by our politicians. It's come to my attention at this very great late stage of my life that people in public life don't always tell the truth. When the Archbishop says, I didn't do it, and then he's gone a day later because it turns out he did do it. And when the politicians say, our economy's growing, we're the envy of the world, we've got the best economy in the world, that's what they say in the UK. This is the average real wage index for developed G20 countries, and there's the UK. You think, how do they get away with this? So this is just a rant. And they get away with it. They can systematically misinform the public, pump out inaccurate, and most of us aren't nerds. But somehow it takes the nerds, which I hope you'd be happy to include yourself, I include myself, to look at the data. And it's a big part of my argument, which is evidence. We need evidence, not just assertion, not just ideology, all very helpful, but we need evidence. And we are being systematically misled by the people who are supposed to be leading us. So that's a rant. I need to stop. I said I was going to take 45 minutes, but anyway. Let me say this, though. One of the questions is whether we can do anything about the social gradient in health. All societies have socioeconomic hierarchies, and if health follows the socioeconomic hierarchy, maybe it's inevitable. Well, this is looking at life expectancy by education, the International Social Classification of Education. So this is primary education and this is tertiary education for 15 countries in Europe. So here's Sweden with the longest male life expectancy at 50 and the narrowest gap between those with more and those with less education. And there's Hungary, Estonia, Bulgaria, Romania, with shorter male life expectancy and a much bigger gap. And a bit like the infant mortality data I showed you, the gap between countries for those with university education is much smaller than for those with primary education. So if you're in Hungary, you don't have to move to Sweden. Just get a university education. They do know how to get better health, but it's not very well distributed. Norway, which is right up there. I was in Norway and a colleague from the Ministry of Health came to, in Oslo, came to, for a meeting, and we decided rather than sit and have a coffee, we'd go for a walk while we met. And she said, do you want to walk up the gradient or down the gradient? I said, down the gradient. So we went east. I was told in Chicago you go south, but anyway. So we went east. And we walked for a bit, and she said, we're there. I said, what do you mean? She said, this is the most deprived part of Oslo. I said, you're kidding me. These are slums done by the Swiss. I expected to see flowers coming out of window boxes, you know. I said, you think this is deprivation? Come to parts of London, I'll show you deprivation. Well, the fact is that being deprived in Norway is not the same as being deprived in Hungary or Estonia or Bulgaria or Romania. So the education's valuable always and everywhere, but it's correlated with much bigger social and economic differences in some countries. I better skip over this. In chapter 10 of my book, I do talk about the global dimension. And there's a good case to make that subsidies to US cotton farmers are leading to suicides of Indian cotton farmers. They live on the edge. And removing US subsidies would allow the world price of cotton to rise somewhere between 6 and 14%. And that would make the difference between surviving and not surviving economically for Indian cotton farmers. And they have 3 times the rate for all India. So we do need to think about the global dimension. And I wanted to call my book The Organization of Misery. I, for about a decade now, have been quoting Pablo Neruda's poem. And because we launched the Commission on Social Determinants of Health in Santiago de Chile. So I quoted Pablo Neruda, the great Chilean poet, and said, "Rise up with me against the organization of misery." Such a telling phrase. So I wanted to call my book The Organization of Misery. And the publisher said, "You can't do that. It sounds so gloomy." So I said, "How about I call it The Organization of Hope?" He said, "Nobody will know what you're talking about." So I called it The Health Gap. But I called the first chapter The Organization of Misery, and the last chapter The Organization of Hope, because I think we've got grounds to be hopeful. Male life expectancy at birth: Colombia, Peru, Brazil, USA, and Cuba. There's Cuba, just been brought in from the cold. The Canadians say go on holidays there quickly before the Americans arrive. So there's life expectancy in Cuba compared with the US. And there's a general narrowing. Things are getting better. Globally, things are getting better. There is a general narrowing. There's significant exceptions, a dozen sub-Saharan African countries where things are not getting better. So there's significant exceptions. But in general, things are getting better. In Brazil, look at the social gradient in stunting, so slow growth in the first year of life by family income quintiles, 1974-75, steep gradient, shallower, shallower, almost gone. It can do it. The evidence says we really can do it. We can make a difference. We know what to do to make a difference. Let's get on and do it.
So we have time for questions. And let me invite you to ask a question. We have a microphone here in case we need it. Michael, let me start out. So you are in a place where there are some doctors around here, and we're interested in educating health professionals. What's in the curriculum that we should include to address these issues for budding doctors?
Well, thank you for asking me, because I wanted to come back to the World Medical Association and the doctors. What we said to the doctors in England, and we're going to say something along those lines to the World Medical Association, was there are 5 areas. The first is education and training. So all of this should be in the training of doctors and what we call postgraduate training. In Britain, for example, I went to talk to the obstetricians, and I showed them the social gradient in teenage pregnancy. I showed them the social gradient in early child development. I said, "Is this any part of your concern? You're interested in getting a healthy baby out and having the mother survive. Do you care what happens before or after? Is this any part of your concern?" And at the lunch afterwards, one council member of the Royal College of Obstetrician and Gynecologists said, "Nothing will happen. We've heard all this stuff. Nothing will happen." They invited me back 3 months later for breakfast, and they said, "We've been rethinking our postgraduate training. We think obstetricians should be the advocates for women's health through the life course." Wow. In fact, if there's anybody pregnant in the room, I'm about to be made an honorary fellow of the Royal College of Obstetricians and Gynecologists, but I wouldn't trust me, by the way. So education and training, getting getting the doctors involved, and they couldn't be a more conservative part of the profession than the obstetricians and gynecologists. They're my great friends, my great allies. The second is seeing the patient in the broader perspective. And again, if I can take a moment, as part of my presidency, or leading up to the presidency, which only happened 2 weeks and 6 days ago, you notice I'm going to start counting down soon. I finish in October next year. It's only 1 year, and I'm going to say, only 3 weeks to go. We had a preliminary meeting that the Canadians suggested in London. It was probably while you were there. Yeah, you were there. So at BMA House, the American Medical Association. They're my great friends now. I know you're going to think, but I get on really well with the AMA people, and they were represented at this meeting in London. The meeting was in a part of London near Euston Station, and I was walking after the dinner to catch the underground train home. And it was about 9:15 in the evening. We'd had an early dinner. And there's a church on the corner, and what would be called the portico of the church was full with people bedding down for the night in sleeping bags. And my first thought was really stupid. It's a bit early to go to bed. I thought, God, really stupid. What else are you going to do? If you go home at 9:15 in the evening, you think, do I want to talk to my family? Do I want to work? Do I want to play? Do I want to do this? Do whatever? You've got options. You've probably got too many options. You think, God, how am I going to fit it all in the day? If you're homeless, you've got no options. What else are you going to do at 9:15 in the evening? You get into your sleeping bag on the concrete and a church portico. So I came back to the doctors the next morning and said, the former president of the Canadian Medical Association, Jeff Turnbull, practiced medicine among the homeless. And he said, I can't treat their diabetes or their chronic liver disease and ignore the fact of their homelessness. I've got to get involved. So seeing the patient in the broader perspective, and that should be part of the education of doctors. The third is seeing the health service as employer, and in fact more broadly as stakeholder. In Britain, the National Health Service employs 1.3 million people. It's an important part of the economy. And the conditions of employment really matter. Our junior doctors are about to vote whether to go on strike. But it's not just junior doctors, it's cleaners and nurses' assistants and lab technicians. The conditions of employment really matter. The fourth is working in partnership. If you're working with young children, you're a pediatrician, you want to be working with other experts who deal with early child development. If you're working with older people, you want to be dealing with social care to deal with the circumstances in which older people live. So cross-sector working. And the fifth, as you'll gather from what I've been saying, is advocacy. We should be the advocates. So I think that should all be part of medical education.
Okay, thanks. I think this is first here.
Thank you. That was a brilliant talk. You made a compelling case that the key determinants lie outside of healthcare. And I look around in the US and even in the UK, where I'm from originally, and see a relatively well-funded health system and conditions in other areas around housing, employment, education, which are going unfunded. Should we be diverting funding from healthcare to those other conditions?
Absolutely not. There's this quaint concept from the past. I know some of you will never have heard of this. It's called progressive taxation. If you want to live in a civilized society, you have to pay for it. And I think it's a reasonable principle that the proportion that you pay should be according to ability to pay. I just reviewed, look at the Lancet from last week, I think it was. I just reviewed Tony Atkinson's new book, Inequality. He's a terrific economist, and he goes through the arguments with patience and care, with all the data, how a more progressive taxation system would not, he knows all the arguments, he's heard Paul Ryan, he knows all of that stuff, that it's not correct that it would dampen initiative. It's not correct that the bankers would all move to the American Virgin Islands or wherever they go. The bankers live in London because they like living in London, because it's a civilized place. They won't go to Monaco. They'll stay in London. So none of that. They won't stop work because there's no incentive to be a wealth creator. He goes through all those arguments. It's all wrong. It's all self-serving rubbish. It's all self-serving rubbish. And the fact is that the top 0.1% have captured political power. And the window of discussion has changed. So to say that if you want to live in a civilized society you need to pay for it sounds impossibly left-wing. It used to sound mainstream. But the debate's been dragged so far in one direction. I mean, we're going through this in Britain with our new leader of the Labour Party. They think he's Stalin and Lenin and Marx all rolled into one. When he raises questions about why we have nuclear weapons, and he says austerity is not such a good thing. There's no sensible mainstream economist who thinks austerity is a good thing. This is mainstream economics. It's being painted as Marxist-Leninism. It's ridiculous. So, no, I wouldn't take a penny away from the health service. I would have a progressive taxation system.
Sam?
Thank you. I think, well, I'll just speak for myself. These are very well-meant and very salient points. And I realize there's a need for equity and equality. But
there's that coming. Yes,
exactly. I feel like in the U.S. at least, those people who are in most need for equity, those people in the U.S. most in need of equity may not be in a place to demand it. Maybe they don't know what they're missing. Maybe they're too focused on their current situation. But I feel like a lot of what's been shown here, and I don't mean to demean anybody.
Least of all me.
I feel like this information needs to be made available to the American public, who are in a position to exercise their right to vote. Voter turnout traditionally is very low, so I acknowledge that. But when politicians are influenced by just a handful, a very small proportion of the U.S., and a small percentage of the U.S. population votes, how do we marry that disparity to the disparities here and create some kind of change?
Well, I think someone should write a book about it. One of the reasons I emphasize the gradient and that we're all involved is this isn't just about the poor, because the poor don't vote and the politicians don't care because they don't lose any votes. But they do lose a lot of votes if the middle care, and the middle are not doing well. I showed you the figures. It's not just ill-educated Americans. The average American isn't doing well. The average American young woman has a much bigger risk than of lifetime, or not much bigger, a bigger risk of lifetime maternal death than in 63 other countries. And for young men, a bigger risk of not getting to 60 than in 49 other countries. The average isn't doing very well. This is your average modal voter who's not doing very well. We do need to get the message out, which is partly why I wrote the book. Get your congressman or whatever, get the New York Times to write about it, get the whoever needs to get the message out. Because this is evidence-based, and that's my argument. This is not just about the hurly-burly of politics. And as we know, I mean, I read Jacob Hacker's book, Winner Take All Politics, and he goes through the various arguments of why income inequality has increased so much. And he says it's politics, it's not economics. That's not a good economic reason, it's winner take all politics. And in fact, Tony Atkinson, whose book I just mentioned on inequality, he begins his book by saying surveys in the United States and the United Kingdom of the general population say the biggest single threat is inequality. Not global warming, not the Russians, not Cuba, it's inequality. So the average, people know that it's a big threat. They may not understand that health and crime and bad things like that are flowing from it, but that's why I tried to take what I'd learned and put in technical reports for the World Health Organization, put in a book that I hope people would read and that would get discussed.
I think we all acknowledge that a sense of control over your health and your destiny are inextricably bound with the level of education and income that you have. But I'm also wondering, is there any evidence that you've seen that it works in the opposite direction, where giving people a sense of control over maybe smaller things, starting with smaller things and growing out, expanding that, whether that in turn leads to increases in wealth or in their own generation or subsequently in future generations?
I don't know if it leads to increases in wealth. I don't know. There may be such evidence, but I don't know about that. But there is good evidence that it leads to increases in health, giving people, creating the conditions for people to have more control. There's been a lot of study of it in the workplace, and that standardizing for level and all of those things, people with more control had better health. So that, and workplace is one place you can do it. But look at what's happening in our workplaces now. They're being incredibly segregated into really interesting, well-paid, highly skilled work, which is terrific, that we're all doing and going to do, which is great. And then the other end, it's poorly paid, need food stamps to survive, uncertain. I mean, as one social commentator said to me, the US experiment of getting single mothers off welfare into poorly paid work with poor conditions, uncertain hours. We call it in the UK 0 hours contracts. I think you call it on call or something, where you've got to be, you're signed up, but you don't know whether you're going to get 80 hours or 4. And you're trying to arrange to look after your children. How are you going to do that? So that experiment's been a colossal failure. And that's disempowering. That's depriving people of control over their lives. And reading these case studies of single mothers at the very bottom, the $2 a day, they give anything for a stable job with regular hours. It doesn't have to be an interesting job like you or I have. Just a stable job. Working on the checkout of a supermarket, but knowing you turn up at 8 o'clock in the morning, you go home at the same time, and you can pick your kids up and do that normal stuff. So it's being disempowered, and their health is really suffering, and we've got good evidence for that. I don't know about whether it leads to income growth.
Anybody over here? Okay.
I think you can hear my voice through that.
Well, we need loud voices. Speak up, yeah.
My question is a kind of an ideological question. But I need to ask you it. Is your belief in the idea that evidence that influences middle class, a change in middle class ideological understanding of their own societies? Is your belief in kind of middle class reform, is that derived from the places where it's already worked? So the places that have the best health and life chances in the world, Scandinavia, basically, and the Netherlands, those are societies which historically have reached the kind of reform they have, not through class conflict. You know, an old Marxist would come along and say, well, you know, the trouble with your philosophy is that in order to have change, you have to have class conflict. And you're really suggesting, well, that's not going to work because you know, we've been waiting for the industrial proletariat to realise there are scribe low rows in history for a long time, and they haven't done it. They haven't overthrown capitalism yet. But if you look at the societies in where this has worked, then they are societies that built their reforms precisely on the kind of sociologically nuanced evidence, if you like, that you know, you look at Sweden and Norway, all of them have their transformations have come about precisely, really, from the kind of ideology, if you like. Maybe I shouldn't call your philosophy an ideology, but from the philosophy that you're advocating, that evidence can influence people who have closer access to power to change, access to power to change.
Well, it's a profound question, and in fact it's a profound set of questions, so there's more than one question involved there. So the first thing is that when I get asked a question about how do you get from here to there, how do you get political change, the honest answer is I haven't a clue. I don't know how you get political change. And when I've said this to political scientists, they say, yes, you do, you're doing it. I say, well, okay, you can write a PhD on it, but I'm not sure. I know what I do, which is take the best evidence and present it in the clearest and best way I know how. And I've been criticized by not being ideological enough. Come on, man, the problem's capitalism and you're not addressing the underlying cause. And I know all that. Yeah, I know all that.
You are addressing.
Well, I think we are addressing with evidence and the way.
With Marxist-Leninist ideology about class conflict, of course you're deconstructing capitalism, but you're deconstructing it with evidence.
And we used the phrase in my English review, which I use in the Health Gap, of proportionate universalism. I say that what I think we learnt from the Nordic countries is the advantage of universalist policies. That a health system for the poor is a poor health system. An education system for the poor is a poor education system. We don't want some special system of healthcare and education for people in Upton Druid Heights in Baltimore. So, well, you poor people can have something and the rest will have something better and different. We want a universalist system. What I learned from Chile, President Lagos of Chile, who became a member of the Global Commission, Chile Solidario, the principle was universalism, bring everybody in. But the proportionate universalism was effort proportionate to need. And so that means, yeah, we do have to work harder for the most deprived. But it's trying to bring them into the mainstream, not create some separate stream for the poor and the deprived, of having a welfare system funded education and health, but everybody else gets something better. So, and my argument about the gradient in involving the middle classes is, yes, in a sense, trying to deal with the democratic deficit, which comes back to your question, which it is a democratic deficit. I mean, and that's partly because of the systematic misinformation being pumped out by the politicians. In Britain, when we had our last election in May, I thought we had a gutter press. I don't know what the next level down from gutter press is, but it got worse. The majority of our press just became organs for one political party. They didn't pretend to present the news or some systematic analysis. And that counts as You know, that Rupert Murdoch's been trying to get the BBC closed down. He thought he's bought most of the media, he'll buy the government, and then they'll close down the BBC and he can control everything. We've got the best government money can buy. He couldn't do that. But that's what he tried to do till he got stung by the phone hacking scandal. And otherwise he would have taken over the whole of satellite broadcasting completely. He already owns the Times and the biggest selling daily newspapers. And this counts as a democracy. So I don't know how to deal with all that, but what I do know how to do is present the evidence. And the evidence that I'm presenting is for the people in the middle. It's in their interest to do it better. It's their children who are not doing as well as they should. You know, I've got nothing against the US. I love the US. You know, my best friends live in the US. I got educated here. I love coming to the US. You know, so I've got nothing against the country. I love the US. But it's not working very well. And it's not working for people in the middle, not just for the poor.
We have time for a couple more questions. Yes?
Hi. Thank you. Thank you for the talk. I had the slide on the Indian farmer suicide raised a question for me. You mentioned that U.S. cotton subsidies could be leading to Indian farmer suicides. But on the other hand, an increase in the price of cotton in India itself might lead to increased cost of clothing for the urban poor. So in a social situation where, or a capitalist situation where the prosperity of one is built on the oppression of another, how do we devise policy that works for all the poor as opposed to attempting to put band-aids on really big problems that we see?
It's very important. I mean, what you're pointing out is that we're dealing with systemic issues here. What I would say, though, is we can break it down into manageable steps. There are international trading arrangements which have something to say about one country subsidizing products nationally and others not. If, as a country, you sign up to those and then don't operate them, that's hypocritical, it's wrong, it's violating international agreements. So quite apart from your concern about, well, maybe the Indian poor won't, I mean, that's a theoretical issue. Let's break it down to something a bit simpler. The US is signed up to certain trade agreements and it's not honoring them. And because it's subsidizing. And we've got the same going on in Europe all the time about subsidies to agricultural products. And you know, part of what the European Union does is try to stop that happening so you get proper trading arrangements. So in that case, I'd say it's relatively straightforward. The US has signed up to a trade agreement that it's not honoring. And when they were challenged over the subsidies to cotton, they said, that's what they said. I mean, the Indian negotiator went off to watch the football because he thought there would be more fun than continuing with the negotiation. So now, the bigger issue, as it were, well, what about the Indian poor? Well, there's a great deal of other things. I wouldn't say, let's allow the US cotton subsidies to continue because we're worried about